And I really appreciate everyone coming tonight. So my name is Anisha Vij. I will be the moderator and host for this session. And thank you again for joining us for the last Living with Liver Disease session of 2023. Oh, we got some more people here to admit. So I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario is situated on the traditional territories of the Anishinaabe, Haudenosaunee, Mississauga, and Mississaugas of the Credit First Nation. We acknowledge and extend our gratitude and respect to all First Nations, Inuit, and Métis peoples for their valuable contributions. Non-Indigenous people have an important role as we work towards reconciliation. And the more we take action and speak up about solidarity with Indigenous peoples, the more we can create lasting change for future generations. So for those of you that are not familiar, the CLF's Living with Liver Disease program has been around for more than 25 years and has continued to serve as a supportive educational tool for both patients and caregivers, as well as people that are looking to learn more about liver health. This program provides an opportunity to increase community-based learning about liver disease and the importance of liver health in the hopes of reducing incidence and impact of liver disease through prevention, early diagnosis, treatment, and care without geographical barriers. Speakers throughout this program have included healthcare providers, allied health professionals, subject matter experts, as well as patient advocates like we will have today. So today's session will address autoimmune hepatitis and its impact on those who are living with it. We're joined by our presenters, Dr. Angela Cheung from the Ottawa Hospital Research Institute and patient advocate Erica Wyatt, who will share her story of navigating autoimmune hepatitis. We will have both speakers present their talks, followed by a question and answer portion. Please feel free to use the chat feature at the bottom of the Zoom screen and ask your questions during the presentation, but note that questions will be answered following the speakers' presentations. Today's session will be recorded and available on the Canadian Liver Foundation's Resource Hub and the Living with Liver Disease webpage, as well as our YouTube channel and Facebook page in the coming days. So for those of you who may not be familiar with the Canadian Liver Foundation, the CLF was established in 1969 and was the first organization in the world created to help people with liver disease. The CLF is committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our 4 core pillars of research, education, patient support, and advocacy. At this time, I would like to welcome our first speaker, Dr. Angela Cheung. Dr. Angela Cheung is an assistant professor with the Ottawa Hospital and an associate scientist with the Ottawa Hospital Research Institute. As a clinical hepatologist and researcher, she has an interest in treating and improving our understanding of chronic liver disease and related cancers, with a particular interest in autoimmune liver disease. Dr. Cheung, over to you.
All right. So thank you so much, Anisha, for this kind introduction. So I'm Angela Cheung, and I'll be presenting on autoimmune hepatitis. And as Anisha mentioned, if you could just hold your questions until the end. So here's my outline. I wanted to do sort of a whirlwind tour of autoimmune hepatitis. I don't have any disclosures for this talk either. So I wanted to start off with this pretty complex slide, really just to highlight how complicated autoimmune hepatitis is. And the reason why it's so complex is because we have a lot of immune cells in the body, and those are typically used to help fight infection, even cancer, and also just maintain the health of the body. But in autoimmune hepatitis, there's an imbalance. So you get sort of a change in the balance of pro-inflammatory cytokines, so things that are inflammatory, as well as sort of an imbalance between the anti-inflammatory cytokines. And this essentially then leads to an attack on hepatocytes or an individual's own liver cells. Now, unfortunately, because it's so complex, we don't know exactly what causes it, and there probably isn't one cause. So this image nicely illustrates that, and this is the case for most conditions, most sort of chronic diseases. So there's the immune mechanisms that I talked about, And so there's altered immune mechanisms we know that occurs in autoimmune hepatitis. We don't necessarily know what their driving factors are. So there's certainly an element of a genetic factor. So there's some people who are predisposed to it. Unlike some diseases, though, it's not simply one gene that is altered, but it will be multiple genes. And there may also be something called epigenomic variations, which are basically alterations on top of the gene, and these can be affected by the environment. And again, we don't know exactly what environmental factors are involved in autoimmune hepatitis, but we suspect that there are some. So those will include things like even viral triggers. The viruses listed here are actually not the most common triggers for autoimmune hepatitis. And in fact, I don't think we really recognize what those triggers are. Most people, if we test them for viruses, if they're positive for viruses, it means actually they're less likely to have autoimmune hepatitis, and it's actually the virus that's causing the injury. But there's most likely environmental sort of viruses that everyone is exposed to, but in people who have sort of a little bit abnormal immune system or sort of a genetic predisposition, then that leads to autoimmune hepatitis. What we know more about, though, is drugs that lead to autoimmune hepatitis. So this is a specific type of autoimmune hepatitis, which I'll get into a little bit later. Listed here are some of the culprit drugs that are most associated with autoimmune hepatitis. So we know that once people take these medications, sometimes that can trigger autoimmune hepatitis even after 6 months after being exposed. And that can lead to a very specific type of autoimmune hepatitis. There's also individual risk factors. So we know that women are more likely to have it. It can happen both in children and in adults. Ethnicity also plays a role. So for example, even First Nations and Indigenous peoples are actually at increased risk of AIH. Hormonal status, because it's more common in women, we think that hormones do play a role, but again, exactly what that role is unclear. And like many diseases you may have heard of, the microbiome also plays a role. So that's the bacteria in the gut. But again, we know very little about this. It's still pretty early days, so we can't sort of target a specific microbiome that can either help or hinder autoimmune hepatitis. So I'm going to spend a couple slides on the different types of autoimmune hepatitis. And there's a couple slides because there's different ways of sort of defining autoimmune hepatitis. So the sort of most basic way, and I would say sort of the more medical way, is to define it by these different types. So there's type 1 and type 2 autoimmune hepatitis. Type 2 autoimmune hepatitis just happens in children, whereas type 1 happens both in adults and children and is more likely to happen in adults. Both can present, unfortunately, with jaundice and liver failure. So when someone's eyes or skin turns yellow and then the liver is very sick. Type 1 autoimmune hepatitis, though, can present in people who are completely asymptomatic. So unfortunately, that can lead to a lot of delays in diagnosis because people with AIH type 1 don't necessarily have symptoms. And they might not present until, unfortunately, they develop jaundice or signs of liver failure. Both conditions are also associated with other autoimmune conditions. So autoimmune thyroid disease can co-occur in both conditions. It's not that autoimmune hepatitis causes these conditions, but unfortunately, autoimmune conditions tend to cluster because there's sort of genetic risks that predispose people to autoimmune conditions in general, and so that leads to other autoimmune diseases. In adults, rheumatic joint or joint disease is pretty prevalent, inflammatory bowel disease, as well as celiac. In type 2 autoimmune hepatitis, and type 1 diabetes, and things like vitiligo are more common. I'll touch upon this a little bit later, but there's also a specific other type of autoimmune liver diseases. So there's PSC and PBC, which can also co-occur, predominantly with type 1 autoimmune hepatitis. PBC only occurs in adults, whereas PSC actually happens quite frequently in children. So most children who are diagnosed with autoimmune hepatitis are actually diagnosed with PSC at the same time. And then in terms of cirrhosis at diagnosis, unfortunately, and again, this sort of goes back to the fact that it's asymptomatic. Over 40% of adults are diagnosed with cirrhosis at the time of AIH diagnosis. A little bit less common in children, but it can still happen and happens in less than about a third of children. This is the other way to sort of define autoimmune hepatitis, though. So there's this quote unquote classic autoimmune hepatitis, and this could be in both adults and children. So this accompanies both the type 1 and the type 2. Again, there's not really a clear association at diagnosis. What that means is there's no clear viral cause. There's no drug cause for classic autoimmune hepatitis. Again, more than 40% of people will be diagnosed with cirrhosis, unfortunately, at presentation. And really the prognosis and outcome, and we recognize this more now, it wasn't as recognized before, is that it is a lifelong condition that requires medication. So only less than 20% of people usually can stop medication because it is a lifelong chronic condition. So it doesn't go away on its own for the most part. That's very different than this drug-induced autoimmune hepatitis. So this occurs more in adults than in children. And again, the most common antibiotics are associated with AIH, is minocycline and nitrofurantoin. And again, it can happen quite a bit after somebody is exposed to the drug. So as much as 12 months later, usually the average is a couple of weeks to several months later. But it can be a bit more difficult to diagnose because of this, because we really do have to take a very thorough drug history over the last year. Usually, and I would say it's more than usually, it's pretty much none of the time should people have cirrhosis with drug-induced autoimmune hepatitis, because it's a pretty acute condition and cirrhosis takes about, on average, we say 10 years, 5 to 10 years to develop. It doesn't present with cirrhosis. So that's a really big distinguishing feature. So if somebody has cirrhosis, then either they have another reason for their liver condition on top of this drug-induced autoimmune hepatitis. Or if they don't have cirrhosis, again, it's less likely to be autoimmune hepatitis, but doesn't necessarily rule it out. The other major difference is that drug-induced autoimmune hepatitis can actually go away. So it's not a lifelong disease. So for the most part, 80% of people can actually stop any sort of medications for autoimmune hepatitis, but we usually typically don't stop until after 2 years. And that's because we want to make sure that the disease is well controlled and that people have normal liver tests throughout that time. And if that is the case, then 80% of people will be able to come off medications for autoimmune hepatitis. In terms of, trying to get rid of some of these, but in terms of this list, so this is just a list of different drugs associated with autoimmune hepatitis. It's not exhaustive, but these are the most common. I suppose this should be changed now. It's not really a possible association here for a lot of these drugs. So a lot of these drugs are now used quite widely in cancer treatment. And so we're seeing actually a lot of people who are getting autoimmune hepatitis from these drugs because they're being used to treat their cancer. But again, the most common, as I mentioned, is minocycline and nitrofurantoin, which are different types of antibiotics. And there's a number of other medications. And so that's one of the reasons why we always ask people to stop. Usually we ask them to stop any medications. As you can see, there's also some herbal supplements in here. And again, this list is not exhaustive, but we ask people to stop any herbal supplements when they're diagnosed with autoimmune hepatitis, because it's possible that there may be an association with these drugs that simply hasn't been uncovered yet. And so we are always pretty prudent about that. Another way to sort of describe the different types of autoimmune hepatitis is based on response to the treatment. So the great thing about autoimmune hepatitis is that it actually does respond usually quite well to treatment. So as you can see, it's very, very unusual to not have any response to medications for autoimmune hepatitis. So if somebody does not have response, then we always sort of take a step back and say, well, is there something that we're missing? Is this truly autoimmune hepatitis, or is there something else going on? Or might there be like an overlap syndrome or another liver disease happening at the same time? So complete response happens in about 3/4 of people, but another 20% will have partial response. And I guess I should highlight that complete response means complete normalization of liver tests. In the past, it used to be we were happy if liver tests were less than 2 times the upper limit of normal, but that's no longer considered acceptable. So complete response is complete normalization of liver enzymes. So specifically, that's AST, ALT. ALP is not usually elevated, but we do want ALP to be normal. So that's what we consider complete response. Partial response is some of the liver tests are still a little bit elevated. And about 5% of patients can't tolerate the medications that we prescribe, at least the initial ones. And so that's not uncommon to see either. So at the top it sort of says, how is AIH diagnosed? So this is a simplified diagnostic criteria. So you can sort of see, if I break it down, there's blood tests, and that's the first several items here. And then there's a liver biopsy. So both of these are really important components to diagnose autoimmune hepatitis. I'll sort of explain why. So these are the different types of variables. These are the cutoffs or the threshold levels of each of the variables. And these are the points assigned to each of the different cutoffs. And then we score all of them. And if it's greater than 6, then it's probable AIH. If it's greater than 7, then it's definite. So that also means if it's sort of 5 or less, then it's a little bit unlikely, or it would be a bit unusual that that person has autoimmune hepatitis. And again, we'd have to look for other things. So for the first blood test, there's autoantibodies. So that's anti-nuclear antibody and smooth muscle antibody. There's also liver kidney microsomal antibody, and then spleen liver antigen antibody. There's also IgG. And so the cutoffs for these are 1 in 40, 1 in 80, and 1 in 40. So you can sort of see there's different cutoffs for them, and that gives you different points. IgG also, there's different cutoffs. And so this can actually go up in cirrhosis as well. And so this is not necessarily that reliable, but if it's quite high, then that gives you more points. As I alluded to before, viral hepatitis needs to be absent. And if it is absent, that gives you 2 points. And that's because some of these viruses can actually lead to some of these antibodies, but it doesn't actually mean that it's causing autoimmune hepatitis. It's simply because the virus is being very active, it tends to actually cause a number of people to develop autoantibodies. But again, that is not consistent with autoimmune hepatitis. The most important thing, though, is the biopsy. So you can sort of see, like, if you just had the antibodies, if you just had the 2 and you had the 2, and you didn't have a virus, that could sort of lead you to probable. But say you only had like 1 and 2, that wouldn't necessarily be enough to tell you that you had autoimmune hepatitis. So what usually pushes people to sort of consider autoimmune hepatitis is a liver biopsy. So the liver biopsy is really mandatory in order to make the diagnosis of autoimmune hepatitis. And if we don't have that, it can be difficult and uncertain whether or not that's truly the diagnosis. And the reason is because these autoantibodies, the ANA can be positive in 25% of the healthy general population. SMA is a lot less common, so it's positive in less than 1%, but it still means that there's 1% of the population for whom this could be positive, and it doesn't mean they have autoimmune hepatitis. And as I mentioned, IgG is not specific for autoimmune hepatitis, so people with cirrhosis can actually have high IgG, so that also is not diagnostic of autoimmune hepatitis. So you can sort of gather from here, it can be a little bit challenging to make a diagnosis of autoimmune hepatitis. And even greater than 6, again, is 6 basically is probable, it's not definite. So it can sometimes be difficult, especially at the initial time of diagnosis. So sometimes it helps to sort of monitor people over time, and that gives us a better idea if somebody has autoimmune hepatitis, because autoimmune hepatitis behaves usually in a pretty specific way. So I also just wanted to give you a slide about what a biopsy looks like. So this is what the normal liver looks like. It's nice and pink. There's areas of like bile ducts and veins and arteries. And then you can see this is a biopsy of an individual with autoimmune hepatitis. So these little sort of bluish purple cells are all the white blood cells and all the inflammatory cells that are basically invading into the liver and causing the inflammation and damage. And then if you have damage for long enough, over many, many years, then that can lead to formation of nodules. You can sort of see these circular areas, and that's surrounded by fibrosis or scarring, which are those blue sort of areas. So just sort of a segue into what liver fibrosis is. So liver fibrosis or scarring is actually what's happening when the liver is trying to heal itself. So it tries to heal itself, but it heals itself in an abnormal way. Fibrosis is not specific to autoimmune hepatitis, so it can be caused by anything that causes damage. So, for example, other like very severe drug injury can sometimes lead to fibrosis usually over a number of years. Alcohol can cause significant damage. Significant fat in the liver can also do that. And there's a number of other conditions can do that as well. I think the important thing also to note is that liver fibrosis is not irreversible. So we don't really even think cirrhosis is completely irreversible. We know that cirrhosis can resolve over time. The liver never goes back to normal, unfortunately, so people do remain at risk of certain things, which I'll get into later. But we know that the liver is one of the few organs that can heal itself. And so that's the great thing, I guess, about liver disease is that liver fibrosis is not necessarily irreversible. But what's important is that the autoimmune hepatitis and any other things that lead to liver injury has to be controlled. Otherwise, the liver is constantly fighting against injury and it can't actually heal itself or reverse any fibrosis. So how is AIH treated? I like to think of it in two steps. So there's what we call induction therapy. So these are medications that help put the fire out. So basically like water, sort of pouring water on a fire. And these include steroids like prednisone and budesonide. Then, however, that's not enough. So if we were just to use this, one, people would get a lot of side effects, and two, the autoimmune hepatitis wouldn't actually be adequately treated. So we need to introduce maintenance therapy. So that's what keeps the fire out. So again, the induction therapy puts the fire out, and the maintenance therapy keeps the fire out. And these include a number of different options. So I listed sort of the most common here. So it's azathioprine, mycophenolate mofetil, tacrolimus, and cyclosporin. So normally first line is the azathioprine. If people have side effects to that, or if it doesn't work, which again can happen in about 20% of people, then most of us would switch to mycophenolate mofetil. Sometimes even mycophenolate mofetil is not enough, or again, azathioprine is not enough. So then we can add on usually tacrolimus, or we can add on cyclosporin. And so most people are on can be on 1 to 3 medications to help treat their autoimmune hepatitis. And that's really dependent on each individual. So it really, again, what we need to sort of get the liver test completely normal, that is what's considered the necessary maintenance therapy for that individual. So unfortunately, there are side effects to the treatments that we provide. So prednisone, most people start on prednisone, and especially at high doses. So that can be very difficult because it can lead to a lot of weight gain, mood changes, easy bruising or skin thinning, insomnia or increased sugars, or if it's prolonged, then even potentially increase the risk of diabetes. High doses greater than 40 milligrams also cause a decrease in blood flow to the hip or knee. And so that can lead to a very serious condition and sort of an emergency condition. Not very common though, but we always tell our patients to let us know if they have very severe hip or knee pain, and we need to taper the prednisone pretty quickly. Budesonide is a type of steroid that is considered not systemic. So prednisone is a systemic steroid. Budesonide is metabolized mostly by the liver, so it acts directly on the liver. That being said, it's it's a medication that's been newly used for autoimmune hepatitis. It shouldn't be given in cirrhosis technically, because there's some evidence that it increases blood clots in the liver. And also, as I mentioned, budesonide usually is metabolized by the liver, and so then that means it has less systemic side effects because the liver kind of uses it all up. But in cirrhosis, if the liver is not able to metabolize things properly, then you still get the systemic side effects. So it's basically as if giving somebody prednisone. It's not clear if it's as effective as prednisone, but certainly if somebody's having a lot of significant side effects, can't sleep, having high sugars, doesn't have cirrhosis, then budesonide is a reasonable alternative. Azathioprine can lead to nausea, vomiting, abdominal pain, or pancreatitis, which is inflammation of the pancreas. Not very common, but something that we watch for. Can also lead to low blood counts, so everybody who's on azathioprine should be getting blood work every 3 months. We always talk about the fact there's an increased risk of lymphoma, which is a type of blood cancer, and a specific type of skin cancer, so not melanoma, but the ones that are not melanoma. That being said, the absolute increase in risk is pretty low. So we go from a 0.02% risk in the general population to, if you're on azathioprine, then it goes to a 0.08% risk. And that's based on not studies of autoimmune hepatitis, but other conditions. So it's actually unclear if this risk is due to the underlying condition or to azathioprine itself. In terms of skin cancer, again, normally the risk is quite low and it doesn't increase very much, but it is still an absolute increase. As I mentioned, the other medications, there's mycophenolate mofetil. So all three of the next ones can cause low blood counts, so we watch for that. And so we can titrate or decrease the dose of the medication if needed based on these counts. Diarrhea can be quite common with mycophenolate mofetil. There's two different brands, so Salcept is more likely to cause diarrhea than Myfortic. Tacrolimus can cause kidney injury at very high doses and sustained doses, so we always check for levels to make sure that these are okay, and we also check for kidney function very regularly. So if kidney function starts to decline, then we will reduce the dose or switch to another medication. Cyclosporin can also injure the kidney, and there's also a slightly increased risk of lymphoma, but again, it's relatively low. In terms of the expected outcomes, I almost didn't want to put this slide because this is all based on old data. So as I mentioned, old data suggested that we could keep liver enzymes less than 2 times the upper limit of normal, and that was adequate. But we now know that unfortunately that is not okay, and that liver injury still happens at those levels. And so this is what these numbers are really based on. That being said, that doesn't affect the untreated numbers. So if somebody's untreated, 5-year survival is about 50%. And that's because, again, most people already have cirrhosis by the time they're diagnosed with autoimmune hepatitis. So if we don't treat autoimmune hepatitis and it continues to injure the liver, then someone can go into liver failure if it's untreated. 10-year survival is also quite low because, again, most people have cirrhosis. So these are usually people who don't have cirrhosis and their disease continues to progress over that 10 years. Again, for treated, 10 years, I tell my patients actually that autoimmune hepatitis, if completely well controlled, actually doesn't affect survival at all. And I do strongly believe that that's true. Again, that's because I, aim for completely normal liver enzymes in all my patients, and that wasn't necessarily true sort of 10, 20 years ago. And that's just because we've learned more about autoimmune hepatitis in that time. So I think that's what these numbers are based on. I do believe that autoimmune hepatitis on its own really doesn't affect survival if, the disease is completely controlled. And we sort of minimize immunosuppression as much as possible. And that's sort of what I said here. The one thing that may affect sort of life expectancy per se is that people with cirrhosis are at risk of liver cancer. So even though I said cirrhosis is reversible, people do still have a risk of liver cancer, but autoimmune hepatitis has the lowest risk of liver cancer in all liver diseases. So the risk is only like 1.6%. So it's extremely low. Liver cancer is also extremely treatable if it's found early, so it can be cured with either surgery or a specific localized treatment. So I mentioned a little bit how we monitor autoimmune hepatitis. So these are the blood tests that we would do. I should have included creatinine in there as well, so just kidney function. But we do all the liver tests, liver function tests, and then just CBC, complete blood count because medications can lower blood count. And sometimes we can do IgG. I tend not to do that if somebody has cirrhosis, but if somebody doesn't have cirrhosis, that could be a good indication. We want that number to be normal, and that means that everything is under control. And as I mentioned, the goal is normal AST and ALT. I imagine some, if not all of you, have had FibroScans. So we've shown that basically in somebody who has complete response, liver stiffness should decrease. And again, that goes to the fact that liver fibrosis can regress and is reversible. So liver stiffness should actually decrease if people are completely treated and liver tests are normal and there's no inflammation in the liver and there's no other liver disease going on. If there is not complete response, then liver stiffness may actually increase by 1.7% per year. So it's not a lot, but it just means that the number on the FibroScan may actually increase a little bit consistently. So if it just goes up, 1 year compared to the next, that's not necessarily helpful because it could just be the location, but if it's consistently going up every single year, then we might have to consider treatment and actually sort of increase the doses of immunosuppression. The gold standard to see if the AIH is completely responding to medication is liver biopsy. That being said, most of us don't typically do it on a regular basis. It did used to be quite routine, but liver biopsy is not without risks. And so fiber scans really sort of replace that in that setting. But the reason why it used to be pretty standard is that 12% of people without cirrhosis might actually have active disease, even though their liver tests are normal. And so again, the fiber scan is a great way to look at that. And so if liver stiffness is increasing, then that does suggest there's still some inflammation going on in the liver. That being said, 74% of people with cirrhosis may actually have active disease with normal liver tests. So it's much higher in people with cirrhosis. And most likely that's because in people with cirrhosis, there's sort of less liver cells that are present that can actually release the AST and ALT, because that's where those tests come from. And so that's likely why you can have normal liver tests with active AIH and cirrhosis. But again, the fiber scan is a pretty helpful test as potentially, well, IgG in people without cirrhosis. And so if liver stiffness is actually improving every year, that's really reassuring, or certainly if it's stable. And so just a mini segue on the fiber scan. So this is the little probe, and essentially these are your rib spaces. And so it goes through the rib spaces, bounces off the liver. So it's both like an ultrasound wave, so basically a sound wave, and then a pressure wave. For those of you who've gotten the fiber scan, you might remember it kind of knocks on your liver, so that's the pressure wave. And so it calculates basically the distance between those two waves and gives us a liver stiffness measurement. And we can then correlate that to a level of scarring in the liver. So that's just sort of what this picture shows here. I present this, there are more updated figures, but essentially there's, depending on the liver condition, chronic cholestatic liver disease is sort of around where autoimmune hepatitis sits as well. That determines basically that this number of liver stiffness determines how much scarring there is in your liver. So again, that's correlated with liver biopsy. So again, it's sort of replaced liver biopsy to understand how much damage there is in the liver. We can't do it in acute autoimmune hepatitis. So if somebody's liver tests are higher than 2 times the upper limit of normal, that will actually skew these values and make it look more scarred than it is. So that's why we don't do this test if somebody's first presenting with autoimmune hepatitis. I mentioned this before, so I'm not going to go through it too much, but other autoimmune conditions can occur with autoimmune hepatitis. So up to 44% of individuals will have other autoimmune conditions. And I mentioned these two specific conditions. So there's primary biliary cholangitis and primary sclerosing cholangitis. I'm not going to go into these in too much detail because they kind of require a whole talk on their own. But both conditions can cause an increase in ALP. That's the third liver test. And so if sometimes people have normal liver tests for many, many years, and then all of a sudden the liver tests will go up, AST, ALT, and or ALP. And so that in that setting, it's really important to check for overlap. So somebody can develop any of these conditions at any point in time. And so there's specific tests for both of these. There's a blood test for PBC, which is the antimitochondrial antibody. And then for PSC, that requires a special type of MRI or imaging test to look at the liver and the bile ducts in the liver. So the reason why I mention these is both of these conditions need specific treatment, and that's different from autoimmune hepatitis. Sometimes to completely be sure, people need a biopsy to assess for these conditions. And both these conditions, if untreated, can lead to cirrhosis or worse liver damage. So it is important to identify both of these. So for the last couple of slides, I just wanted to touch upon, what people with autoimmune hepatitis can do for both their liver health, but also their health in general. So there are no specific recommendations for AIH itself, except for to maintain medications and normal liver tests. I wanted to put this up because these are, you might have heard about it earlier this year, but it's the new Canadian guidelines on alcohol. So I wanted to highlight it because I was quite struck by this. So the guidelines now say zero alcohol is the safest, can take 2 drinks a week, and that's the least amount of risk. But that being said, we can sort of see, even just based on this, For women specifically, 1 or 2 drinks a week can increase your risk of cirrhosis quite dramatically. And so it doesn't take very much. And so somebody who has another liver disease, these numbers would only increase. So I always tell my patients essentially that they really should abstain from alcohol if they can. A couple times a year is okay, but even 1 drink a week on a regular basis can injure the liver quite dramatically. And unfortunately, alcohol is associated with a whole bunch of other things, as you can sort of see here, with the red being sort of the highest risk. The same is the case for men, though less. And so for men, up to sort of 14 drinks will actually start to increase your risk of, say, liver cancer, for example. Liver cirrhosis starts to increase already at like 4 drinks a week. So again, I don't give different recommendations for men and women. I always tell people to try to abstain from alcohol if they can. Other things that people can do is to maintain a healthy weight. And it's for 2 reasons. The medications are weight-based. So in my experience, I've found that people, the higher people's weights are, the less effective the medication is. And there's essentially a ceiling to the doses of medications that we can give. So we can't continue to increase them based on people's weight. So that actually limits the effectiveness quite a bit. Increased weight also increases the risk of fatty liver. And fatty liver is a different condition that causes accumulation of abnormal fat in the liver, but this can also accelerate fibrosis or liver injury. Other important things to do in general, but particularly if you're on prednisone, is to maintain adequate calcium. So it's an equivalent of 500 milligrams 3 times a day. And it does have to be spread out. It can't be taken all at once, or it can be due through dietary means, so a serving of sort of dairy-containing products or calcium-containing products 3 times a day. Vitamin D, generally our recommendation is 2,000 units a day because it's based on sun exposure. And if you're on Imuran, then you really shouldn't be exposing to yourself to the sun. And so 2,000 units a day is generally the recommendation. It's also important to maintain weight-bearing exercises for bone health. I put osteoporosis candida here because it's just a great resource for different types of weight-bearing exercises. You might actually see another Angela Cheung on there, so it's not me, but somebody who with my same name is an expert in osteoporosis. You want to avoid herbal supplements, so there's no evidence that things like milk thistle, turmeric, or curcumin are helpful, and sometimes, unfortunately, they can be harmful because, as I mentioned, some herbal supplements have been associated with autoimmune hepatitis or sort of drug injury of the liver. There's also a lot of evidence in general that coffee helps the liver. So it used to be that the recommendation was caffeinated coffee. Now we know that both caffeinated and decaffeinated coffee can help, 2 to 3 cups a day. It's also important to make sure that you wear sunscreen, have sun protection, and also have regular skin exams. And that's mostly because of the Imuran. We know overall immunosuppression seems to be associated with increased risk of skin cancer. So I make sure that all my patients adhere to this as well. Really important to do blood tests at least every 3 months when things are stable. It might need to be more frequently if things are not stable. And that's because of looking for medication side effects, but also because flares of autoimmune hepatitis can happen at any time. And they're not based on anything any individual does. So it's not that they ate something or necessarily did something that causes a flare. Unfortunately, these can happen at random. So that's why we always advise blood tests every 3 months and sometimes in between if people aren't feeling well. Also important to do ultrasounds regularly in the setting of cirrhosis. So those are every 6 months, and those are to look for liver cancer. Even though the risk is really low, I think it is important to look for it because, again, it can be easily cured or treated if found early. And it's also really important to take medications for this condition. And if there's any side effects, to really talk about that with the prescribing physician, just so that they know, because as I mentioned, there's multiple options for treatment. And so sometimes we just need to work on finding the best one. So that's the end of my talk. So I really appreciate your attention. And I did put questions, but I think we're saving questions till the end.
Thank you so much, Angela. That was fantastic. Just a second. There we go. That was a fantastic talk, and I really appreciate you sharing all of that really great information with us. I would now like to invite our second speaker of the evening, Erica Wyatt. Erica is a public servant residing in St. John's, Newfoundland. After navigating a challenging journey to uncover the source of her health concerns, she received a life-altering diagnosis of autoimmune hepatitis in March of 2023. Motivated by her rare condition, she now advocates to both raise awareness and combat the stigma associated with AIH. Outside of her professional life, Erica enjoys to garden and crochet. Erica, over to you.
Thank you, Anisha. And thank you, Dr. Cheung. That was a very informative session. I learned some new things. I have some questions taken down for the Q&A session. I'm looking forward to that. So good evening, everyone. I'd like to start off by saying that AIH is a highly individualized condition. As you saw Dr. Cheung talk about, it impacts each of us differently. When I was asked to speak about this topic, my initial intention was to recount my own struggles. I was officially diagnosed with AIH only in March of this year, and I really struggled with the lack of information available to understand the disease. I was referred to liver.ca for more information, and I noticed they had a peer program. I thought, great, I'm going to reach out. I'm going to talk to someone else who has AIH. I sent an email, and they responded that they didn't have anybody for me to talk to. So, that experience highlighted the need for a platform where people could hear directly from those who have AIH. Therefore, I'm going to give a brief glimpse of my journey over the past year, but primarily I'm going to focus on voices of other AIH patients as well. So, as you probably noticed in the last slide with Dr. Cheung, autoimmune hepatitis is challenging to diagnose. In my case, it took about 3 family doctors, an allergy specialist, an internist, and a gastroenterologist from 2016 to 2023 to get my diagnosis. My first symptom was fatigue, and that was initially dismissed. Unexplained symptoms led me through a maze of misdiagnosis, from being prescribed antidepressants to assumptions about alcoholism to judgments regarding my tattoos and my weight. It was a very long, frustrating process until I just so happened to get sick enough that my new doctor suspected AIH based on significantly elevated liver enzymes and visible symptoms such as jaundice. Last year around Christmas time, my ALT was in the thousands, and I got really sick. I had gastro symptoms, and that's how it was discovered. So my journey over the last year, it's involved a lot of medical appointments, from gastroenterologists to dermatologists, therapists, even specialists in cannabis. So it just reflects the multifaceted impact of AIH on various aspects of our health. For example, I've had 34 blood work appointments since January. The high dose of prednisone I started on and subsequent chemotherapy introduced new challenges, including hallucinations from the prednisone when I was on a really high dose and substantial weight gain of 60 pounds. Additionally, the immunosuppressants confined me to my house for the first few months of the year, illustrating the isolating nature of the treatment. Additionally, I have ADHD, and I'm no longer able to take my medication due to the impact it would have on my liver. So navigating around that, both in my work and personal life, has been quite a challenge. And as I noticed in Dr. Cheung's presentation, is that sometimes you have multiple autoimmune diseases at the same time. I was diagnosed with Hashimoto's the same time I was diagnosed with autoimmune hepatitis. So unfortunately, the whirlwind of medical encounters is not unique to my case. It's a reality for many AIH patients. It extends beyond physical health to mental well-being, where coping mechanisms like therapy, and in my case, crochet, really become essential to get through the diagnosis. The stark reality of never being able to consume alcohol again and being cautious in the sun adds a lot of layers of complexity to your life if you can't prepare for that before you get diagnosed. Now, I want to share some insights from a collective of AIH patients. These reflections shed light on what friends, family, coworkers, and fellow AIH patients should understand. Importantly, these perspectives are not intended to diminish the experiences of those with other health conditions, but they're vital with the narratives within the AIH context. So I'm part of a lot of Facebook groups and communities with AIH patients. So I reached out to see if they had anything that they wanted me to discuss. and I've received an overwhelming response. So over the next part of my talk, I'm just going to try to conclude, I guess, some things that they would like us to know. So first, autoimmune hepatitis isn't something that you can catch. The name is really unfortunate. Many AIH patients have to go through a lot of barriers within the medical community. So I've heard stories of people, going to the emergency room and being put in quarantine the moment they say they have autoimmune hepatitis because the staff don't understand what autoimmune hepatitis is. Or I've heard stories of people saying that their spouses can no longer donate blood because when they fill out the form, it says that they live with someone with hepatitis. So as soon as we say the word hepatitis, it's assumed that we're contagious or we caught it from some kind of undesirable behavior. Hepatitis just means inflammation of the liver. AIH, from my understanding, is not really a liver disease. It's an autoimmune disease that affects the liver, and I could be wrong on that, but that's what I've come to understand in my journey of trying to find information. So basically, it's our immune system attacking the liver, and it does not come from a virus. Alcohol is also not the cause of our liver disease, but it could trigger a flare-up or other side effects. So something that AIH patients want you to know is to please respect if we say no to having a drink. We're not trying to be rude. It's just a necessary choice for our health. Not being able to drink is actually a struggle for many of us. For myself personally, I'm a young woman who lives in the city with the most bars per capita in the world. It's how people socialize here, and it's been quite a struggle having to navigate where drinking is the norm. Most of us with AIH don't even tell people that we have autoimmune hepatitis. We like to say that we have an autoimmune disease that affects the liver, just to avoid harmful judgment from others. So we really shouldn't feel embarrassed or ashamed by something that we have no control over. The next topic that really was heated in the conversation was fatigue. Pretty much everyone had something to say about fatigue. The best way that I can describe my own fatigue since being diagnosed is basically I'm walking around with one of those heavy lead jackets, like what you wear at the dentist when you get an x-ray. When we say we have nothing left in our tank, we mean it. Sometimes we're so drained that even simple tasks become a huge effort. So it's not laziness, it's just the harsh reality of living with this disease some days. But we do have good days. I don't want to scare anybody in thinking, if you're here trying to see if you have it, don't be stressed out. There are good days. However, good days don't mean that we're going to be healed. This is a chronic illness, and fatigue is just part of it. Even if we're in remission, like me, I'm in remission and my blood levels are normal, I still experience chronic fatigue often. Just because you see it doesn't mean that it's not there. The next thing that came up was the emotional and mental impact, feeling like a burden because we're not as capable as we were before, and dealing with loneliness and isolation. It's really tough. Depression is a common companion in this journey. Uncertainty and future concerns weigh heavily on our minds. When I was diagnosed in March, I went into my appointment for my biopsy, and I was basically told my liver was so scared that I would possibly need a transplant within 3 years if I didn't respond to medication. And then I couldn't see my gastroenterologist for 3 months after that appointment. So I honestly believed for the first 3 months that I had 3 years left to live. It was terrifying. And, we're not looking for pity, but stable improvements don't mean we're completely fixed. We live in constant worry about our health and what our future holds. And a good day doesn't always guarantee a good tomorrow. Another thing is we have to limit our stress and be cautious around people who are sick. One single flare could be detrimental to our health. So if you are a loved one watching this, first of all, I want to say thank you for attending this session. But please keep your distance if you're sick and respect our choices such as vaccinations or wearing masks if that's what we need to do to feel safe. Another aspect of the mental impact is no longer knowing who we are when we get diagnosed. Trying to navigate through our new normal, having side effects such as weight gain, moon face, and acne from the prednisone, we might even look different. So many people agree that the impending feelings of future death is not really understood by many of our loved ones, nor taken seriously, which is really unfortunate. This just adds to the mental stress that we already have when people don't take the time to understand the severity of this disease. The loneliness and isolation it causes due to people giving up on us because we can't participate the way we used to can be very, very overwhelming. And figuring out our new limits can also be a struggle. A lot of us were very healthy individuals before getting diagnosed. So grieving who we used to be is a large part of the process. The lack of understanding and awareness about AIH is also a major issue that came up. Even health professionals struggle to grasp it sometimes, and having to explain it gets really exhausting. Also, our own lack of understanding is extremely difficult. Like, how am I supposed to explain it to someone if I don't quite understand it? There's so many parts. Like that chart that Dr. Cheung just showed had a lot of parts to it. Like it's very, very difficult to wrap your head around, especially if you're new to this. So, it's overwhelming. I understand that if you're new to this and if you're wondering if you do have autoimmune hepatitis, like, don't panic. There's supports out there for you. You'll figure it out, and there are supports for you, so don't stress out too much. Education is so powerful. So if you have AIH or you suspect you might have it, coming to events like this are crucial to understanding your health. So I encourage that. Another thing is advocate for yourself. Trust your gut. A common thing that I see amongst AIA patients in the online groups that I'm part of is that they say only a hepatologist can diagnose you. Don't go see a gastroenterologist. What I have to say is my gastroenterologist, she is absolutely fantastic. So depending on your location, what resources you have available, find the healthcare practitioner that works best for you. I know it can be really difficult to navigate here in Canada with our current healthcare system. Wait times can be really long, but stay strong, make them listen, don't give up. I had to go through 3 doctors over the course of 6 years to find someone to take me seriously. Sometimes with this disease, it doesn't really become apparent until it's too late, and that's just the way that it rolls. But don't give up, keep pushing. Lastly, medication and health management are critical. Unsolicited advice can be extremely harmful. Our medication is not a choice. It's what's keeping us alive. AIH is potentially fatal without it. So, basically the medication is suppressing our immune system so it will stop attacking our liver. Anything labeled to boost our immune system is counterintuitive and could cause harm. I noticed that Dr. Cheung had a list of things like supplements and everything that you should take. Often friends and family will suggest herbal teas or supplements or just change your diet. We understand that you're trying to be helpful if you're a family member here watching this or a friend who has suggested that, but we ask that you acknowledge that unsolicited advice could be harmful to us. So please keep these perspectives in mind. It's not just about the symptoms, it's about the broader challenges, physically, emotionally, and socially. I just want to say thank you to the Canadian Liver Association for having me, and to Dr. Cheung. I certainly learned some new information. Also, thank you to the AIH patients who contributed to the conversation to help me to prepare for this panel today. And thank you for the support you've provided me over the past year.
Erica, maybe I can say something, but thank you so much for sharing your story and also for reaching out to other patients with autoimmune hepatitis. I think that's really helpful to understand sort of the collective journey of individuals who are living with autoimmune hepatitis. And I wanted to highlight, which I don't think I highlighted well in my talk, so thank you for reinforcing that, is that unfortunately autoimmune hepatitis, there is huge stigma in being diagnosed with liver disease, because you're right, people and unfortunately even medical practitioners will assume that patients are drinking alcohol or have fatty liver disease. So I also I think in the Ottawa Hospital are reasonably good at it. We try to do biopsies as much as possible, because unfortunately, fatty liver is becoming, very common. So we know that it's going to affect, 1 in 3 Canadians, but that may lead to people having a misdiagnosis of other extremely severe conditions like autoimmune hepatitis that require very specific treatment and will not go away with simply weight loss. So I think that's something that's really important to emphasize. For us in the medical community, we need to make sure that we're always vigilant and we're not assuming that someone has another disease, especially when all the blood work seems to point in another direction and all the symptoms seem to point in another direction. So thanks for sharing that. And I think another thing that you highlighted that I hear, a number of my patients also ask about is diet. and herbal supplements and everything. And as I mentioned, unfortunately, there is no diet or herbal supplement that has been shown to help with autoimmune hepatitis. I think there's even been like books or there's websites on sort of like an autoimmune diet. And some of my patients have tried that, but unfortunately, there's not really clear evidence. And it's mostly because, as I showed in that first slide, the immune system is so extremely complex. And the mechanisms for autoimmune hepatitis is likely slightly different for each individual because of this interplay between genetics and environment and their medications and their own immune system. And so to be able to say that one diet would be able to sort of cure autoimmune hepatitis for everyone, unfortunately, I think is sort of simplifies the whole process of autoimmune hepatitis. And I wish that we could simply, give a specific diet recommendation or a pill that would cure autoimmune hepatitis, but unfortunately, we're not there yet. That being said, there are research studies happening on autoimmune hepatitis. It's a tough area to study because it is so rare. But there are companies that are looking to see if we can get new medications, not necessarily a cure, but at least more medications for people who don't have complete response to existing therapies. So yeah, I just wanted to thank you for your talk.
Thank you both so much for sharing your stories, and Dr. Cheung for sharing all of that really helpful information. Erica, that story was very powerful, and I'm sure that will be helpful to a lot of people. So I wanted to kind of move just into our question and answer period. I know we've got a few questions here in the chat that I think would be really helpful as well. So I will ask Erica and Dr. Cheung to unmute, and I will have some questions for you. So my first question is for Erica, and that is that we know how important self-care is for folks who are living with liver disease. Is there anything you can suggest in terms of self-care tips for someone living with AIH?
Yeah, I have really taken self-care up a notch since my diagnosis because I have no energy. So I have a lot of downtime these days. I enjoy having baths in the evening. I find they really help mellow me out. I also took up crochet. So I've made over 20 sweaters this year, and I entered into a craft fair over the weekend. I find that, especially with my ADHD and not being able to stay medicated with that, I can hyper focus, and it's a way for me to cope with, other things going on in my life. But I find if you have like a hobby, such as crafting, binge watching shows, a lot of the times we're stuck inside. Make the most of it. Garden in the spring when the sun comes out. Wear your sunscreen, of course, but there's lots of ways to, take care of yourself, and it's really important because stress could, cause a flare, and you don't want to be stressed out. So, take it easy, take it day by day, and listen to your body. It's especially hard when you first get diagnosed because you're used to being healthy and you're used to doing things, and it takes time to start to understand what your new capabilities are.
Really great advice. I think that's helpful for a lot of people. Obviously, having hobbies are great, but I think it's even more reinforced with something where you might be spending a lot of downtime kind of inside or with yourself. So thank you very much. My next question is for Dr. Cheung. It's kind of a couple questions in one. So, feel free to answer how you'd like to. But Donna's asking what the post-transplant recurrent rate is for AIH, and are there any preferred treatment protocols, and if that changes with a PBC AIH overlap post-transplant?
Yeah, so unfortunately, all autoimmune liver diseases have a recurrence rate about 15 to 20%. So unfortunately, transplant is not necessarily a cure, though it can be for the majority of people, which is great. Yeah, that's an area that still requires a lot of research in terms of how to prevent recurrence. So a number of centers will continue prednisone. So post-transplant, people get high doses of prednisone as well to help prevent liver rejection. And then normally people come off prednisone, taper off prednisone over time. But in autoimmune hepatitis, many centers will continue at least 5 milligrams of prednisone with the hope that will prevent recurrence. In terms of the other medications for transplant, there isn't a clear-cut guidance on which medications are better. That being said, a lot of people with autoimmune liver disease are at higher risk of liver rejection. Normally, that can happen in 30% of people after transplant, but that number can be a lot higher in autoimmune hepatitis and other related diseases. And so that means they might have to continue on like 3 medications post-transplant, as opposed to some can actually continue on 1 medication post-transplant. So it may alter the amount of immunosuppression that happens post-transplant, but there's not clear-cut guidelines on like specific medications that should be used post-transplant.
Okay, thank you very much. I actually have another one for you. Is the loss of menstrual periods a symptom of AIH?
So it can be. So if somebody has cirrhosis, can cause amenorrhea, and unfortunately liver failure can also cause that. So if somebody is sort of very sick with any chronic disease, it can cause loss of periods. And then usually the medications aren't associated with that. So once the disease gets under control and the cirrhosis begins to regress, periods can come back.
Okay, thank you. My next one is for Erica. Are there any questions that you felt that asking your doctor when you were first diagnosed that would have been helpful, or were there any that were helpful when you were recently diagnosed?
That's a hard question to answer because my journey was so long, and I feel like I was asking the right questions. I just wasn't being heard. The first doctor, when I went to ask about fatigue, I said, "Can you please check my thyroid?" Which is funny because I have Hashimoto's after all said and done. And they said, "You know what, you're just overweight, and I think you have depression because of it." And he just prescribed me antidepressants. I saw an internist, and she was like, "There's no way that you could be autoimmune after having all these symptoms." I had a rash. My mouth was exploding in sores. And she was like, "You're too young, and young people usually go downhill, and you're healthy." You know, after being diagnosed, she actually called me back into her office and apologized for not ordering me a biopsy 2 years ago when I presented with symptoms. And then one of my doctors thought that I was an alcoholic. And after 10 months of not drinking and convincing her I wasn't an alcoholic, that's when she, referred me to the internist, and then the internist didn't get me a biopsy. So I tried, I asked questions. So sometimes you just have to find the right practitioner to take you seriously. So I can't really offer any advice to that because clearly it didn't work for me. But, I think, advocate for yourself and trust your gut is, unfortunately with the healthcare system, it's hard to just switch a doctor. I know that in St. John's where I am, it's really hard to get a family doctor. And sorry, that's my cat. And, you just have to do the best with what you can and advocate for yourself as best as you possibly can.
Hey, thank you. Next one is for Dr. Cheung. Are there any kind of limits on the bottom kind of ceiling of how low blood counts have to be before adjusting medications?
That's a good question. Not generally speaking, no. But if somebody's getting, so there's different blood counts. So there's the red blood count. If somebody's becoming very anemic, which means that they have a low red blood count, then generally we would adjust the medications. But some studies actually show that if it's starting to cause anemia, that's more effective. That being said, we don't want the counts to go too low. The white counts are where we have most of the data. So if specific type of white count neutrophils are less than 1, we will decrease the dose because that may increase the risk of infection. And also if platelets don't usually drop that much, and usually if they do drop, it's because somebody has cirrhosis or that their cirrhosis is getting worse, not necessarily from the medications. So there's not really a lower limit for the platelets.
Okay, thank you. Let's see. Are you familiar with any enzyme changes when taking Entyvio, which is an ulcerative colitis medication?
Yeah, Entyvio. So yeah, Entyvio can be associated with high liver tests. It's not very common, but it is something that we monitor when people are on medications for ulcerative colitis, because a number of the medications, particularly infliximab, can cause autoimmune. Actually, has been associated with autoimmune hepatitis itself. So if somebody does have high liver tests, they should be tested to make sure this is not like what we call de novo autoimmune hepatitis. So people unfortunately can develop autoimmune hepatitis, at any point. And then also if that's negative and all the other workup is negative, to consider either adjusting the dose of Vito or considering a switch. But that's pretty big decision, so it'd have to be in pretty thorough discussion with your gastroenterologist.
Okay. I have one last question for Erica. What is one piece of advice you would give to someone with a new AIH diagnosis? One last piece.
Don't panic. Don't panic. Try to get educated, I guess. Try to find the right information. Don't pay a lot of attention to Google, and stay calm. That's the advice I would give.
All right, thank you so much. So with that final answer, that concludes this Living with Liver Disease session. I would like to take the time to thank our speakers, Dr. Angela Cheung, for a very informative talk, and Erica for sharing such an impactful and meaningful story. As mentioned, this session will be available on the CLF Living with Liver Disease webpage, the CLF Resource Hub, our Facebook page, and YouTube channel over the next few days. You will receive a survey at the end of the session to collect your feedback. Please feel free to let us know how you find these sessions and how we can improve. Keep an eye out for upcoming webinar sessions in 2024, and we are looking forward to an exciting year of educational webinars. For more information on these sessions, they will be available on liver.ca next year. And if you don't see the session posted yet or minimal information, please do check again in a few days or weeks, as we're likely finalizing some of those details. Thank you all for attending today's Living with Liver Disease session on autoimmune hepatitis. And if you have any additional questions or comments, or would like to stay up to date, please follow us on social media or connect with us through our website, or you can always send us an email at clf@liver.ca. Once again, thank you very much and have a great evening.